So welcome back to the PET revision session. We're talking about the PET ebook for semester one. So we're just going to roll through this very quickly. So if that's available in right at the top, okay, and you can see some of the names of the sessions have changed, but they're all basically the things that we cover in semester one. All of them have the learning aims of each of the lectures and everything about the module that you need to know. So the first chapter is about why we should exercise. Okay, there's some basic learning outcomes, understanding why we're doing what we're doing, preventable diseases that we talked about right at the very beginning, about getting 22 minutes per day. And then it's also got links to all the podcasts. Just give me a thumbs up in the chat if you've had a chance to listen to some of the podcasts, guys, and you've enjoyed them. Just give me a little thumbs up in the chat if you had a chance to listen to them. Yep, fantastic. So it gives you a little bit of insight, okay, into the worlds of which we're talking about, of which PET is very relevant. So we've got our targets for health here. We've got obviously the acronym of Sport Billy, which you know and you've done to death. We've got all the acronyms from PET that you need to know. Okay, so we've got everything covered within those particular sessions. And then at the end of every chapter, okay, they've got some questions for you to answer. So if you haven't had a chance to do that, okay, it's a really nice time over the Christmas period before you sort of download all that information from 2020. So at the end of each chapter, there's things that you can go through that are going to be really helpful. And all the chapters are included as well. So our second one was the components of fitness, and about all those components of fitness, about the motor. Okay, there's Stu with his six-pack there. The motor and the physical components, about what they are, and again, questions at the end of each chapter. So if we go through these, we're looking about functional movement. I'm talking to my friend Matt Walden, who's an osteopath in that podcast. We're talking about the 4 Ps of functional movement, about those level 1 functional movements. Okay, don't need to go into that. Really good book from the library. Okay, has anyone actually, give me a thumbs up in the chat if you've had a look at the reading list, guys? Has anyone, I know it's been difficult to get into uni this term, okay, but has anyone actually gone in and had a look at some of the books that are available? Or are you doing everything online? Just type in book or online, just to give a bit of feedback. Everything purely online. Okay, just bear in mind there are some books available in the library. This one's particularly good, Movement That Matters, okay, by Paul Check. We've got our functional movements at level 1, functional movements at level 2, functional movements at level 3. We've got a discussion around physical literacy, the importance of physical intelligence. A lot of our patients won't have this physical intelligence. As physio students, you have physical intelligence, otherwise you probably wouldn't have picked physio as a career. Okay, understanding those developmental milestones along the way, and the importance of physical literacy with our disability community, massively important. And then some more questions at the end there. Then we moved on to things like functional strength and conditioning, understanding why we implement level 1 functional movements and how we do that, learning that functional movements are on a continuum of health and performance, understanding what non-functional exercises are and then what functional exercises are. So sometimes we need to do non-functional in order to get to functional. So for instance, you know, you might need to do, as we talked about in our last session, inner range quads in order to work with standing, but really we want to get back to the functions of things like sit to stand, lunging, stair climbing, so on and so forth. So we've also got functional exercises for the upper limb as well. We can see the bicep curl is a non-functional exercise, whereas throwing is a highly functional exercise. Then we've also got our load with our goals and our sets. We've also got the rest factor that we've incorporated into that, about whether we're working strength, endurance, okay, and not working hypertrophy. Then we've got balance and proprioception. That was our next session, learning about the components that make up balance. Okay, so can you just type in to the chat box, what are the 3 components that make up balance, guys? What are those 3 components that make up balance? Okay, not quite. So there's 3 components to balance. Can you remember what they are? Yeah, these are relevant to balance and proprioception. Well, the first one is proprioception. Yes, Holly. So we've got proprioception is the first one. Okay, then we've got 2 other systems that make up balance. What are those systems that make up balance? The vestibular system, yep. Okay, and you've got another one begins with V, the visual system. Well done, Rebecca. Okay, so they're the things that make up, and then we've got all different types of receptors that we have there. Okay, and they're all influencing the body. Particularly, we've got how balance and proprioception works. Here we are, we've got the vestibular system, we've got the visual system, and the proprioceptive system. Okay, so important that we understand that. Remember, we've got the Golgi tendon organ and the stretch reflex to revise, spinal arcs, all that sort of thing. And then we've got the 5 indicators of stability. Okay, head position, shoulder position, midline stabilization, pelvic position, and foot position. So when we're ever teaching anything, we're always using those. Okay, and then we've got our various ways of progressing our exercise. Progression and regression of balance exercises going to be very important as you become physios. And then we've also got this referral to where the joints are and what type of joint are we dealing with. So at the top, we've got a normal joint. Okay, we've got a little bit of play within the joint, but not too much. Okay, if we've got too much play, we've got a hypermobile or a loose joint. Okay, this will make things like shoulders and hips particularly vulnerable. Okay, we might get a stiff joint where there's just no play in the joint. Okay, or alternatively, we might get a compressed joint. And then we've also got joints that lack motor control. So this ball and bowl analogy is actually really, really good for describing the different types of joint that we have. Then we've also got some outcome measures for balance and proprioception. I was in the lab on Tuesday doing some research, and we were using the Y balance as a part of one of our tests. Okay, both before I did a task and then when I was fatigued after a task, measuring my performance, obviously repeating that 3 times for accuracy. And then we've got another set of questions about balance and proprioception for you to answer along the way. Biomechanics, do you remember biomechanics? Here it's important to remember the difference between open and closed chain exercises. So can you give me an open chain exercise? Type in the chat, guys, any sort of open chain exercise that you've got. Open chain exercise for anything. Could be quads. So throwing is open chain. Yep. Hamstring curl is open chain. Yes, Rebecca. Well done. And now give me a closed chain exercise. Give me an example of a closed chain exercise. The squats, the deadlift. Yep. Just 2 of you answering there. Okay. So we've got it even tells you down at the bottom. So we've got these 3 planes of movement that we move in. Really important that we understand that, and we're able to stretch in those dimensions as well. So what I want you to do is stand up for me. So stand up and then just do a quadricep stretch. So you're stretching your quadricep. Okay, get that stretch on your quadricep. I'm stretching my right quadricep. And then what I want you to do is lean away from the quadricep you're stretching. So here, when you're stretching your quadricep, you're working in the sagittal plane. If you lean over, we're stretching in the frontal plane or the coronal plane. And then if you look away over your shoulder, we're stretching in the transverse plane. Okay, so we've got 3 dimensions of stretching: forward and backwards, side to side, and then rotation as well. Okay, important that we understand 3-dimensional movement because we move in 3 dimensions. So the principles of biomechanics, we've got 8 principles. We've got force motion, how much force is required. Then we've got force time, how much force is required over what time. Then we've got resistance to change. This is what we call inertia. Then we've got range of movement that can be either linear or angular. Then we've got balance and stability, which is, can we maintain our center of mass over our base of support? The coordination continuum, this is about optimal motor timing. Segmental interaction, which is about local joint isolation. And then we've got the sum of all segments, which is either open or closed chain kinetic exercises. Okay, so they're the 8 principles of biomechanics. And we've also ventured on to levers. If you remember levers, okay, so we've got the axis, the resistance, and the force, which is RF. So level 1 levers have the A in the middle. Okay, level 2 levers have the R in the middle, and level 3 levers have the F in the middle. Okay, so it's important that we just understand a little bit about levers. Okay, so what type of lever is this, guys? Type it in the chat. What type of lever is this? Level 1, 2, or 3? It's level 1. Yep. Okay. Level 1 because the axis is in the middle. Yeah, good. So move on to this one. What type of lever is this? Level 2, yeah, is because the R is in the middle, and then no prizes for guessing which one's next. Level 3, which is the most common within the body. Okay, so most common within the body is going to be the level 3 levers. Here, where the resistance is, where the force is in the middle. Good. So we've got open chain exercises. This is an example of an open chain exercise where the distal segment is free to move. We're normally talking about a single joint. And what we have to be careful about this is it produces shearing forces at the joint. And shear is generally not a good thing. So we have to be careful of that. Okay. We also might need to isolate particular muscle groups. So here we're isolating the quads. And the function of this is not just sitting down doing some knee extensions, but the function is actually kicking, either in martial arts or in sports, kicking a ball or something like that. Then we've got a closed chain. A shearing force, okay, is either, so what's happening is we've got translation of movement across here, okay, or some rotational forces. Okay, we want to minimize the amount of shearing that we've got and maximize the amount of compression. Okay, the body loves compression, particularly the lower limb, the ankle and the knee. They love compression. Okay, but what they don't like is shearing forces, because shearing forces will stress things like the meniscus in the knee and things like that. Does that answer your question, Rebecca? Yes or no? Yeah, okay. So here we've got a closed chain exercise. The distal segment is supported by contact with a supporting surface like the floor. Normally we're talking about multiple joints, and the good thing is that they've got compressive forces, okay, that are able to be dissipated throughout the body rather than isolated forces that might shear the joint, and they're generally involved in the functional movements. Okay, so functional movements for open chain, throwing and kicking are level 2 functional movements. Okay, so just make sure that you know the difference between open chain kinetic chain exercises and closed kinetic chain exercises. Know that open chain are going to produce more shearing forces, which is generally a bad thing, and then closed chain going to produce more compressive forces, generally a much better thing, particularly with regard to proprioception. So if you do a squat, that's a lot easier to feel where your joints are in space than if you're doing a fast movement like a kick or a throw. Okay, just give me a thumbs up in the chat if that makes sense to you guys, in terms of knowing where your body is. Okay, during a kick or a throw, because they're so fast, it's hard to know where your body is in space. Can you give me a thumbs up if that makes sense to you? Yeah. Okay, good. Right, So we're moving on. So we want to talk about where the load is, and where the load is will determine, okay, what sorts of pressures that we've got. So here we've got the difference between a front squat and a back squat. So it's just you doing a squat, okay, with either a load in front of you or a load behind you. So if we do the traditional back squat with the bar on our back, or maybe we're wearing a backpack, we look here at the moment arm of the hip, and we're producing much more moment arm at the hip than we are the knee. Okay, so if you've got somebody with knee pain, this would be a really good way to do that, because we're not doing a huge amount around the knee, it's all around the hip. Whereas if we change the weight to a front squat where the load is at the front, maybe holding a ball out in front of us or doing a goblet squat, can we see that we've got a larger moment arm at the knee? Yeah? So what I want you to do is just be aware, okay, that when we're doing a front squat, this is a more true squat because the hip moment arm and the knee moment arm are symmetrical. Whereas when we're doing a back squat, okay, we tend to have a greater hip moment. Just again, just give me a thumbs up in the chat if that makes sense to you when we're talking about moment arms between the hip and the knee. Yeah, okay, so we're happy enough on this. That's great. So we're going to move on to the deadlift, which is a hip hinge with vertical tibias. Okay, so a deadlift is just picking up a dead weight from the floor. So this is lifting a box up from the floor. Okay, so forget about the term deadlift. It's a hip hinge. Okay, and we're picking stuff up from the floor. Okay, we want to encourage as straight a back as possible so we can use the big muscles of the hamstrings and the quads and the glutes, sorry, without using the small interspinal muscles there. And all you're doing is you're picking up a box from the floor. It's nothing rocket science at all. So here we've changed the load. Deadlift is when you're picking something up from the floor, like a box. And then a good morning, okay, is different for that. Here we're focusing on the eccentric load. So we've got the bar behind the back, and as we lean forwards, what muscle are we working eccentrically? As we go from this position to this position, what muscle group are we working eccentrically? What muscle group is lengthening under load there, guys? What muscle group? Yep, it's your hip extensors or your hamstrings. Excellent. Okay, that's exactly what we're doing. So the good morning is a hip hinge. We just changed the position of the load. That's all we've done. And again, we've got the questions on biomechanics. What I want you to do is tell me the difference between the squat and the deadlift in terms of moment arm. Okay, so which has an equal moment arm at the knee and the hip? Which movement has an equal moment arm at the knee and the hip? Is it the squat or the deadlift? Which one, guys? Equal moment arms. It's going to be the squat. Yeah, so the squat has equal moment arms. Let me show you again. So this is what we want as a squat. The knees are coming forwards, okay, and there's an equal movement, an equal moment arm between the hip and the knee. So that's the definition of a squat, okay. Now with the deadlift, we've got a huge hip moment arm and a very small knee moment arm, okay. So that's the difference between the two. Yeah, okay. Don't get confused when we talk about moment arms. It's not as bad as you think. Okay, so then we've got the mind muscle connection. This is the muscle physiology that we've just talked about. So this is the session that we've just had. It's covering all the things that we need to know. It's got that very confusing picture there. Okay, it's got all the things that we've just on the slides. Remember that we're going to be weaker at inner and outer ranges and much stronger in mid-range. Okay, why are we stronger in mid-range? Type in the chat, guys. Why are we stronger in mid-range? Type it in the chat for me. Why are we stronger in mid-range? Okay, yep, so we've got, yeah, you're sort of right. Will, you're sort of right. Holly, okay, give me a little bit more. Talk to me about cross bridges. Talk to me about cross bridges. You've got more cross bridges, yeah? Optimal amount of cross bridges, optimal overlap. There you go. Okay, and that is going to make the muscle stronger. So muscles are always stronger in mid-range. Okay, good. We've got the acronym ICE. So we've got the isometric. Iso means the same, metric means length. Then we've got the concentric and the eccentric. And we can play about with these different movements, okay, the concentric or the eccentric, okay, to make the muscle fatigue. Okay, so for instance, if we were to do biceps, what we could do is we could hold the muscle at mid-range against a resistance, okay, and then we could also do partial reps, so we're focusing on the lowering to halfway, focusing on the lowering, or we could focus on the concentric and fast lower, concentric, fast lower. So we can start, once we start messing about with the concentric and the eccentric, we can start thinking about the forces that we need to apply. Okay, and this is particularly important with things like the lower limb. Yeah. And things like walking, when we come on to eccentric dorsiflexion. Remember that as the heel strikes, the control of the foot downwards is an eccentric contraction of the tibialis anterior, okay, of the dorsiflexors. And that's really important that we control that movement down, okay? Otherwise, we get like this kind of slapping of the foot, which wouldn't be good to absorb load if we're talking about AMP1 stuff. Okay, so here we've got this example here, okay, of the actin, the myosin binding. And here I've got some other videos. Normally I'd record a video at least once a year of you all doing this, okay, and the full-timers and the part-timers. Obviously you've seen that video already. It's just a shame we're not going to have a chance to do that. Then we've got some questions about what's going on. Okay, so we'll do that. We've literally just done that. Just tell me what is released from the sarcoplasmic reticulum. So what is released from the sarcoplasmic reticulum that's going to help with muscle contraction? It's calcium. Yeah, calcium ions. Yeah, okay, very well done. You guys are all over this. So now we've got range of movement and mobility. Okay, so we've covered things like range of movement before. We know that we've got this natural physiological range. So this is the range that we don't want to stretch beyond. We could go all the way up to here before we rupture, okay? But we don't really want to go any further than this. And this is the stress and strain curve that we think about when we're stretching tissue. Okay, here are the contraindications for stretching. Okay, massively important that we remember contraindications for stretching, because that's a safety issue and it's very easy to fail on safety. Okay, so here we've got that spinal arc, okay, and the muscle spindle, the stretch reflex, okay, right in the belly of the hamstrings there, okay, when we're doing, for instance, like a toe touch there. Okay, we've got what's happening at the muscle spindle, the Golgi tendon augurs, about the Pacinian corpuscles, okay, all just a nice reminder there, okay. We've got our goniometer measurement, okay. What movement of the shoulder is this, guys? What movement of the shoulder is this? It's shoulder extension. Okay, I know we haven't done the upper limb yet, okay, but it's just checking, keep you on your toes, okay. Then we've got the three types of stretching. We've got the manual stretching. This is when the therapist will stretch you. Mechanical stretching, serial splinting, okay, like for things like talipes. And then self-stretching, and that's when the body, when the patient takes responsibility, i.e. the why of your responsibility, and they start stretching themselves, Okay, are you doing your stretches like none of my patients ever? Okay, we got those two different types of stretching, the static and the dynamic. So when we're doing a warm-up, okay, would we normally do a dynamic warm-up and stretch or a static warm-up and stretch? What would we do? What's the better one? Dynamic. Yeah, why do we want to do a dynamic warm-up, okay, and not a static stretch warm-up? Why do we want to not do dynamic stretching in the warm-up and not static stretching? Oh, this is a bit trickier, isn't it? It is more specific to the activity you're doing, yeah, definitely. Any other reasons? Exactly, Anthony. Less chance of injury, okay? Yeah, gets you moving. What happens is that we know that if we stretch for too long, anything we're static stretching for too long, we can make the muscle weaker. Okay, and that's not what we want. So what we want to do is activate the muscle with that dynamic warm-up. Whereas if we do static stretching at the beginning, we can actually decrease the muscle's capacity to work. And then we've got the stretch shortening cycle, which is plyometrics. So what we've got is we've got this eccentric contraction followed by this period of amortization, okay, then into a concentric movement as well. So what we do is we drop down, we try and make the amortization phase, okay, as short as possible. Okay, so we want this phase as short as possible, okay, and then we can do this. So this is effectively the jump, okay? So we've got eccentric contraction of the quads, okay? We've got a pause, and then we've got an explosive concentric contraction, okay? And this is called the stretch shortening cycle, jumping, or plyometrics, okay? Really important that we do that. And what level of functional movement are plyometrics? We do them repeatedly. Level 1, 2, or 3? 3, yeah, okay. So they're level 3 functional movement. Okay. Good, good, good. We've got some various questions. Okay, so type in the chat one contraindication for stretching, guys. One contraindication for stretching. Can be anything you like, but give me a contraindication for stretching. Stunned silence. Open wounds. Well done, Will. Anybody else? So yeah, so we would say fracture in the area rather than just a broken leg, because we can still stretch the rest of the body. Okay, so a fracture in the area, hematoma. Yeah, well done, Liam. Anything else? Need a couple more. Skin condition. Yeah, you need to be more specific. Maybe fragile skin, cancer in the area. Yeah, non-compliance. Yeah, well done, guys. You're all over this. Great stuff. Then we've got our communication and feedback. So we've got two methods of communication with our patients that are really nice and evidence-based. What are those two methods of communication, guys? Something and something. What are those two methods of communication that we did a couple of weeks ago now? No, methods of communication. So I don't want to tell you what they are. There's something interviewing and ABCDs. Motivational interviewing is one of them. Well done, Anthony. Okay, so motivational interviewing is one. What's that? Yeah, the other is lifestyle counseling. Okay, rather than, so that it's the ABCDs of lifestyle counseling. Well done, Rebecca. Okay, but it's lifestyle counseling and motivational interviewing. They're the two things where we persuade our patient to do exercise. Okay, because most of them are not doing that. And when we're teaching this skill, okay, we need to think about the various learning styles, the visual, the auditory, the kinesthetic, and the analytical. So can you remember the acronym IDEA? Okay, what does the I stand for? The I in IDEA, what does that stand for? introduce, yeah, or introduction of. And which learning style, when we do the I of idea, are we hitting? When we introduce something, which learning style are we working? What's that? Not the visual system. When we introduce something, we talk about it, don't we? So what? It's the auditory learning system. Yes. Yeah, it's not a trick question. So when we introduce something, we're using the auditory learning system. And then what's the D of idea? What's the D of idea? Demonstrate. Yes, James. Okay. Yeah, fantastic. So which learning style are we working on when we demonstrate something? The visual system. It's you're all over this. Okay. And what is the E? What is the E of idea? Execute. Yes, James. Well done, Will. Yeah. Okay. So when we execute something, what system of learning are we using? What system of learning are we using, guys? The kinesthetic. Exactly that, James. And then finally, what's the A of idea? What's the A of idea? It is adjust. Yep. Okay. Well done, Lauren, Will, and James. Okay. And what what learning system are we using? Okay. When we learn, well, the patient learns to adjust in order to be correct. It also begins with A. It's the analytical system. Yes. Oh my goodness, that was hard work. That was harder than it needed to be. You can tell it's the last session of the year. Okay. Right. Just give me a thumbs up in the chat if everyone's still intact. Are you still intact? Not too bad. We're nearly there. We're nearly there. Rebecca's okay. Anthony's okay. We're nearly there, guys. Okay. So we've got the acronym OARS. So why would we ask open questions? So why do we ask open questions to our patients, guys? What's the point of asking an open question? Gets more information. You find out more information. You get opinion rather than false R's. Yes. Okay. Fantastic. And then why do we use affirmations? Why do we give the patient positivity and affirm anything they've done, even if it's a tempting exercise? Why do we do that? Ah, the big dog is here. Hey, Stu,
Woof,
how we doing?
Woof, woof. How's it going?
Yeah, well, we've only got 24 in the room. I think I've bored them all to tears. Most of them left after the first Kahoot, but we've got 24 that are still going strong. Stu, you got anything you want to add? Any words of wisdom?
No, I'm done. I have no wisdom left to give. I'm an empty shell.
You have worked incredibly hard with the first years, even more so than usual. Just thank you.
Do you know what? I've had nothing in return. I've had nothing back from them.
Nothing, I don't believe that.
Nothing at all. It's like no, it's nothing at all. Oh, now they're listening.
Now they're switching on. Stuart, you give them everything, and they take everything.
I'm just a broken man, Dale. Broken man. Anyway,
it's been a hell of a year, Stuart.
You've
outdone yourself. I particularly like the socially distanced photos that you had to do.
That was the hardest photograph. Do you know, I photographed every planet in the solar system. I photographed nebulae millions of light years away. It was harder getting 21 meerkats to sit in a field. You know. Anyway, I'm just come to say goodbye. It's been a pleasure, guys. I'm going. I'm done. I'm spent.
Give Stu a wave.
Bye, guys.
Thanks very much, big dog.
Love you. Love you, guys.
Thanks, Stuart. Much appreciated. Okay, Stuart works hard for you guys. You're very lucky to have him in your first year. He's been working extra hard, keeping you guys on track. Right, where were we? We were talking about affirmations. Okay, so it's important to affirm and repeat the positivity of anything the patient's done. When we're trying to build rapport, we want to compliment the patient. We want them to be rewarded for any sort of physical activity, and that's really important. We understand that. Reflections really about stating what the patient has said back to you, almost using you as a sounding board. So you're just reflecting back what the patient has said. That also helps the patient to kind of realize and reflect on their own statements, almost like the patient's talking to themselves. And then we use summaries. Why do we use summaries, guys? Type in the chat. Why do we use summaries? Why do we summarize something to the patient? Shows active listening. Yes, James. Why else? Make sure we're on the same page. Yeah, I like that analogy. Okay. So, and what do we start the summary with? What's the phrase that I asked you to remember? What's that phrase that I asked you to remember when we do the summary? Can you remember, guys? Yes, Anthony. So if I understand you correctly, okay, very well done. Top of the class there. Well done, my friend. Okay, so we're going to move on to, obviously, we've got to think about the environment. We've got to think about the acronym idea of how we do stuff, and also the rewards and enjoyments, okay, for what we've done with the patient when we're thinking about communication. Remember, we've got 3 learning stages. We've got the cognitive when we're thinking about the task. We've got the associative when we're kind of working stuff out and problem solving. And then we've got the autonomous where you can do other tasks on top of what you're doing already. Those 3 stages of learning, really, really important. Okay, and then we've got the ABCDs of lifestyle counseling, okay, where we assess on scale of 0 to 10 about what sort of things are going on with that patient. Then we got to think about the barriers to exercise. Normally it's time, I haven't got enough time, okay, and then we've got to get them to commit. So commitment therapy is a thing, and if we can get them to commit to something, we then get them to demonstrate that about how they're going to do that. And we might use somebody's smartphone, okay, so using a health app on the phone, okay, similar to a bit of like track and trace, okay. So just on that one, okay, just have a look at your smartphone. I know it's there. How many steps have you done today, guys? Okay, type in the chat. How many steps have you done today? I haven't done a huge amount today. I'm on 2,300. So I'm well behind what I should be. Okay, so Will's well ahead of me. So's Rebecca. Okay, so's Megan. Yeah, okay, I'm well behind. Okay, but I have swum for an hour today, and I didn't obviously take my phone in the pool. Okay, so I've done more than my 22 minutes, but I just haven't done my steps. Okay, and then we've got some questions about that. Okay, just very quickly, guys, type in the chat the 3 stages of motor learning. What are the 3 stages of motor learning? We've just done them. Come on. What are the 3 stages of motor learning? Cognitive, then associative, then autonomous. Well done, Liam. You got all 3. Fast on the typing, fast fingers there. Okay, exercise prescription now. Okay, as we give them RX, which means as prescribed. Okay, so we did exercise prescription the other day. Don't forget to listen to my podcast with Paul Comfort. Okay, Paul teaches on the Masters for Strength and Conditioning here at the University of Salford. So we've got the FITTI principle. Okay, so the FITTI principle is commonly used for fitness instructors, but what principle do we use in physio? What's the acronym for the principle we use in physio rather than FITI when it comes to overload? It's the drive principle. Excellent. What's the D stand for? What does the D stand for, guys? Duration. Excellent. Good. What does the R stand for? Okay, it's either rest or recovery. What about the I? What does the I stand for? Intensity, yeah. And the V, what's the V stand for? Volume, excellent. And then finally the E, what does the E stand for on drive? It is the energy system. Well done, Lauren. You're all over this. Absolutely brilliant. Okay, there it is. Okay, the drive system. Good. So when we've got all this information together, so we've been teaching you for 12 weeks now, 11 weeks, and we've given you 12 sessions about how to teach exercise. It's probably a lot more complicated than you thought. So what we've got to do is we've got to come up with our description of what's going on, and this is our needs analysis. Okay, what's the task? What's the individual? We're going to watch them perform the movement that they can or can't do. Then we're going to link that to our knowledge base about what they're struggling with and then why they're struggling it, forming a hypothesis. Then we're going to implement some exercises. Then we're going to evaluate whether that's made a difference. We might get some quick changes with some motor cues, or we might have to wait for some physiological changes, particularly when we're doing things like cardiac rehab and the heart, which might take a little while there. So we've got to think about the evaluation of the task. What level of functional movement is it? What components of fitness are required? Okay, and with joints and muscles are going to be potentially at risk. Then we've got to think about the individual. Is the individual up for the task? Are they capable of what's going on? We've got our order of efficacy that we prescribe exercises first. So we give range of movement exercises first. Then we work on balance and proprioception. Then we work on strength, and that strength soon becomes endurance in an isolated way. Okay, then we work strength to endurance in an integrated way. Then we work strength to endurance in a load or resisted way. Then we start adding rapid functional movements. And then finally, we add power, things like kicking, punching, jumping, for example. So that's our hierarchy of exercise and fitness that we understand there. Here we've got our sets, reps. We've also got our rest in that as well. So when we're working strength, guys, how long should we recover in between sets? How many minutes should we recover in between sets for strength, guys? Okay, yep. So anything from 2 to 5 minutes. Okay, if we're really working strength, so the strong men in the world, okay, they basically do 6 repetitions and then have 5-minute break, and then do another 6 and have a 5-minute break. Their workouts take like 4 hours, okay, simply because they have to have this huge amount of rest in between. How about, what's our rest for muscular endurance, guys? For muscular endurance, what's our rest time? If we're working muscular endurance, okay, how much should we rest, roughly? Yep, about 30 seconds is the standard. Okay, so that way you've got time to dissipate a little bit of lactate before you go again. Okay, we are on to exercise rehabilitation planning. The rehabilitation planning is probably one of the most important skills to learn, because we've got to understand exactly what's going on. And we've got, so how do we divide the patient journey up? How do we divide that patient journey up? Now, what are the 3 terms that we use to divide that patient journey? Something, something, and something. Stages of rehabilitation. What are the stages of rehabilitation? Type it in the chat for me, guys. Yep, so we've got subacute, that's the one in the middle. So what have we got before that? So we got acute, subacute, and then chronic. Yep. Okay, or early, mid, and late stage rehabilitation. Okay, so that's what really we're thinking about. Hopefully, just give us a thumbs up in the chat if you've listened to my podcast with Claire Minshaw. Okay, have you listened to my podcast with Claire? Yeah, fantastic. Good, good, good. So we've got acute, subacute, and chronic stages. So when we're working with acute, what are the three components of fitness that are the most common for acute injury? Range of movement, balance, and one more. You're right. Well done, Rebecca. James, well done, William. There's one more. Range of movement or flexibility, balance, and is a physical component of fitness. Strength. Thank you. Okay. And then it is strength. Well done. And then if we're working chronic, okay, so when the patient is much further down the line and they're returning to function, what are the three components of fitness we're more likely to be working on then? When someone, say we've got an athlete, power. Yeah, so power. What else? Endurance. Yeah, yeah, good. And one more. Power, endurance. One more, guys. Help me out here. Come on. Speed. Yeah. Okay. Speed. Excellent. Well done, Rebecca. Okay. So we've got the principles of SPOT, specificity, progression, regression, overload, and timeout. Okay. And that's what we've got to think about at each of these three stages. Really important that we focus on SPOT. Okay. Because that's the sport of a sport Billy. So we've got this super compensation theory. So basically we train, okay, at this point here, we do some training, we damage the muscle recovers stronger, okay, which is called super compensation. And then we're ready to go again. Yeah, and eventually, because we're going up, okay, we get better and better as we respond to the stimulus. And this is the prevent and provoke. So we provoke ourselves short term to get benefits long term. Okay, so specificity is basically you get what you train for. And here is, so we need strength early on, okay, but we need power in late stage. Okay, we need balance and proprioception early. We don't really need it at late stage. Okay, and we've got performance, i.e. things like speed, we need it much later on. We've already identified that just now. Okay, so this is our 6-stage progression model. Doesn't have to be like this, it's just a guide. So we start off, we isolate and educate, then we add some resistance. Okay, then we're going to introduce functional movement, then we add functional movement with some resistance, then we start working multiple muscle groups from core to the extremity, and then we add in the various components of fitness, balance, speed, rotation, all that sort of stuff. So that's our 6-stage progression model. Just give us a quick thumbs up in the chat if you're happy with our 6-stage progression model. Quick thumbs up in the chat. Good, good, good. Okay, we've got our formula for 1 repetition max. This is, we can basically work out our 1 repetition max from our 10 repetition max, because 1 repetition max we probably wouldn't be doing with our elderly or injured personnel, but we could do something that's sub-maximal and get the same result. Okay, we've got to make sure that we're giving the correct rep range for the component of fitness that we want to do. We don't want to be prescribing 3 sets of 10 for hypertrophy because we're not bodybuilders, we're physiotherapists. We're not interested in building muscle, we're interested in building components of fitness. Okay, and then we've got our acute workload, which is our weekly workload, and we do that, our rate of perceived exertion and the amount of time we've been doing that workload. So normally we're after 150 minutes weekly of moderate activity, so that rate of perceived exertion might be about 3 to 6, for example. Okay, that will be our acute or our weekly workload, and then we can compare that to our chronic workload, which is basically 4 weeks worth of that, and then we take an average of what we've been doing. Okay, so you can then have your weekly workload and your monthly workload, and then you can compare the two, and this is what we call the acute chronic workload ratio. And this will give you a number, and we want that number in our safe zone between 0.8 and 1.3, because that means that we're progressing no more than 5% each week. Okay, if we progress 6% each week or above, we could be risking an injury because we've progressed our patient too much. This is particularly important with regard to things like cardiac rehab, for example. Okay, then we've got some questions there. So in summary, okay, you have finished the first semester, okay, of PET. You can now prescribe exercise, okay, to a very high level. You've got the clinical reasoning skills, you've got the assessment skills, and you've got all the programs you need on either Rehab Guru or PhysiTrack. So you can give the gift of fitness, okay, i.e. you can give everyone in your family a prescribed and personal exercise program. Great for your exercise prescription practice, and also you give your family a gift. What could be more important than fitness at Christmas? So there are the subjects that we've covered in their entirety. Remember that movement truly is medicine, but we've got to prescribe that medicine. Okay, it's really important that we're a role model to our patients, and that for our own health, we get those 22 minutes of fitness per day. And like I said, give the gift of fitness. Okay, you can prescribe it with Exercise Guru or PhysiTracks, and how about designing an exercise program for your loved ones this Christmas? Okay, right, that is it. It is all over. Give yourself a big round of applause in the chat, guys. There's 19 of you left. There's meant to be more than this. Okay, everyone's either traveling home or they're just knackered. Thank you so much for your participation with what's been probably our most challenging intake ever. You guys have absolutely been wonderful. Have a great break. You've certainly deserved it. And thank you for all your enthusiasm and your effort. And we will see you in 2021. Okay, I salute you for staying online. And thank you so much, guys. Fantastic. Have a good break. Have a good Christmas. Okay, stay fit. Do your 22 minutes. Okay, and we'll see you next year, guys. Thank you very much. Thank you, guys.